CataractCoach.com, IOL calc case series number 10. Let's talk about amblyopia. Now, in this umbrella term, I want to encompass a few different cases. Case 1 we're going to talk about is a patient with anisometropic amblyopia. So one eye having a different refractive error than the other eye. Typically, this is seen in patients who are hyperopic. Let's say the normal eye when they were young was a +1 hyperope. The amblyopic eye was a +4 or 5 hyperope. And that anisometropia caused them to basically ignore a lot of the signals from the amblyopic or the highly hyperopic eye. Those patients then at some point got glasses to correct them to ametropia in both eyes, and then did patching, of course, to force them to develop the pathways on the weaker amblyopic eye. That's one case. You can also have anisometropia, like a case I'll show you here, where the patient has a difference in not the spherical equivalent, but rather astigmatism. This patient's very myopic in both eyes, and the spherical equivalent in each eye is around the same. The difference is one eye had 3 or more diopters of corneal astigmatism, and the other had only about 1. So there's a relative amblyopia there. Now, fortunately, in this patient, there wasn't a huge difference in the best corrected visual acuities. So the eye with 1 diopter of astigmatism in that patient could correct to 20/20. The other eye could correct with the full RX to 20 out of 30. So pretty reasonable. So this is a patient with lifelong anisometropia, but not so much with the myopia, because the amount of myopia, spherical equivalent, is about the same in each eye. It's just the right eye, for a reason, has a lot more astigmatism. So even the old glass that we look at, 4 diopters of astigmatism in the right, 1 in the left. And we'll look at the autorefractive that was done as well. So similar here, right eye, about 3 of CIL here, and you can see it's all in the cornea. Left eye, a lot less astigmatism, and again, that's just in the cornea. So a lot of anisometropia, but not in terms of spherical error, but rather astigmatism. And now we can look a little more detail. Again, here's the autorefractor for the right eye, minus 350 of CIL. Look at the cornea here, almost 3 diopters of SIMK astigmatism. There it is, that bow tie at about 90 degrees or with the rule. And then the left eye has a lot less. Again, left eye in the refraction, only about a diopter and a quarter of CIL. Similarly in the cornea, about a diopter or so. And you can see smaller bow tie and less of that with the rule astigmatism here. In that case, let's talk about which eye do you do cataract surgery on first? I do surgery on the eye that has the better visual potential. That's the eye that can correct a 20/20 in this patient's prior history, now has a cataract. By making that eye first, I can get that outcome that I want, which is great vision in the patient's dominant eye, and give that patient that sharp acuity that he or she's looking for. Then second, I'll follow with the amblyopic eye. Now in this case, it's a mild degree of amblyopia. So my question to you is, can we do monovision? Can you do monofocal lenses, toric monofocals, do the good eye for plano, the other eye, can you just do it for -1.5 or something, for some near vision or intermediate vision? Well, you could, but the best outcome may be from correcting both eyes to distance. In general, it's tough to do monovision if one eye has a best corrected potential of 20/20 and the other eye has a best corrected potential that's significantly less than that, let's say 20/40 or less. That's not going to be so useful to the patient. I think in those eyes, you're more likely to get better results if you do both eyes for the same refractive target. So in this case, plano OU, and then the patient will end up wearing glasses for any near work. Now, there are other patients who sometimes have anisometropia, but it really didn't cause much amblyopia, and those are like the high myopes. Patients who started off wearing, -2 or 3 or 4 of myopia in their youth, but as the myopia progressed, that axial elongation, one eye ended up -9, one eye ended up -12. There's really often very little amblyopia there. And so in those eyes, you can have a little more freedom to do what you want in terms of refractive outcomes. And those patients often, if you're that myopic, more than -10, you may actually want to stay a little myopic after the IOL surgery, so aiming for maybe -1 or 2 refractive outcome. Now, some patients have an amblyopia due to ocular misalignment or a strabismus. Those patients have often had surgery to help align the eye at some point in the earlier years of their life. And those patients, again, I think are often best served by keeping the refractive errors in the two eyes about the same, because that's probably what they started with. And again, I do surgery for the non-amblyopic eye first to give the best potential outcome, and then do the amblyopic eye. If you do it this way, the patient will say for the first time, wow, what a beautiful result. Please do my other eye, with the hope that it may also fix the amblyopia, but you know it won't. So you can say to the patient, let's temper that expectation. Your second eye is the amblyopic eye. Even with a perfect focusing of the eye, perfect cataract surgery, perfect IOL placement, and zero refractive error, that eye still is not going to have the 20/20 sharp, dominant acuity that you have in the non-amblyopic eye. So temper their expectations. They'll still say, hey, no problem, just try your best. And being hopeful. And they'll have a nice outcome, but as you know, you can't fix amblyopia with any type of refractive or cataract or IOL surgery. And the last thing I want to bring up is I work together closely with some strabismus specialists, some pediatric ophthalmologists who also do adult strabismus. And I had a patient sent to me recently who had a later onset diplopia in life. And this patient's diplopia was intractable. The patient had strabismus surgery a few times, and as an adult, a 70-year-old adult, still could not get alignment of the eyes and still was incredibly symptomatic from diplopia. And so this strabismus surgeon sent the patient to me and made a request. Please make one eye plano and the other eye -3 to really separate the eyes. That's a high degree, an extreme degree of monovision, plano and -3. But because we split the two eyes up, it solved the patient's issue of diplopia. Because only the one eye was seeing far and only the one eye was seeing near. So there are times where you may do things a little differently here. So those are the points to consider when you have a patient with amblyopia and you're also doing the IOL calculations. Thanks for watching.